Hello, I'm Elena Sang for the Power of the Patient Project. Today we're joined by Dr. Danielle Ofri, clinical professor at Department of Medicine at NIU Grossman School of Medicine and attending physician at Bellevue Hospital. Dr. Ofri is also a co-founder and editor-in-chief for Bellevue Literary Review. Dr. Ofri has numerous publications and books with a focus on doctor-patient relationship, including What Patients Say, What Doctors Hear. Dr. Ofri has spoken on TED Talks, Deconstructing Perfection, and Fear and Necessary Emotion. She regularly writes for the New York Times and was featured on the documentary Why Doctors Write. Dr. Ofri speaks out about the realities of doctor-patient relationships and some of the struggles that prevent successful encounters. She advocates for the necessity of creating great doctor-patient relationships, even with obstacles, and how that ultimately improves patient health outcomes. Please welcome Dr. Danielle Ofri.
Thank you. It's so nice to be here.
It's a great pleasure to have you here. First, can we start off by having you explain what the doctor-patient relationship is and why it is important?
Sure. And I'll broaden this to include all healthcare providers, the relationship a patient has with a nurse or the physical therapist. For shorthand, I'll use doctor-patient, but includes anyone who's caring for the patient. And so this is the connection that we have that enables medical care to happen. I mean, you could Google your symptoms, get a result of what you have and get the treatment, and that might work. But that is very different than seeing a doctor or a nurse and confiding in them about what's going on and getting the care in that manner. And so if you kind of can define the doctor-patient relationship about what it's like when you don't have it and how that will feel kind of sterile and how important it is, particularly when you're very sick and when there's a lot of uncertainty, when everything's healthy, it's not as important. Or when things are very simple, you sprain your ankle and just, wait it out with ice, that's fine. But when you're facing complex illnesses, things we don't know what the answers will be, when there's a lot of uncertainty and ambiguity, then having the connection, the personal connection with your physician or your nurse, then allows that medical care to go forward in as best as care and in as best a way as is possible.
I see. Thank you. What do you think are some of the problems or obstacles in healthcare setting that prevent this great relationship that's necessary for the care to be created?
Gosh, how much time do you have? So there are lots. Unfortunately, our system seems to work against it. And I'll start with the issue of time. So when I see my patients, I'm allotted 10 or 15-minute slot. Again, if someone is completely healthy and is just here for a checkup, that's fine. But if a patient has 5 or 6 chronic issues, illnesses, which many patients have these days, if they have any sort of psychosocial challenge, maybe there's stress or depression, maybe there's food insecurity or financial insecurity that's causing stress that's affecting their health. Maybe they don't speak English and we use an interpreter. Maybe there are cognitive issues. There are all kinds of things that need much more time. And just the ability to get to know someone. If someone is taking 18 medications, I can spend the entire visit just sorting through that and we'll never have a chance to get to know them. Who do they live with? What's their circumstance? How do they come to this country? What do they do for a living? All of these things are so important. Tell me what's important to you in life. Those things are critical to understand a patient, and without enough time. So that's one of the hardest things. The second thing is the electronic medical record, which really is now ubiquitous, and there are many great things. And I have my beefs with the EMR, but there are many wonderful things about it. But it does often interfere with connecting with people. I mean, one of things that helps a lot to make a connection is eye contact and the chance to simply talk. And the EMR makes it very difficult because doctors and nurses are forced to spend their time documenting in the EMR while they're talking to the patient because there's so much to do. You can't possibly do it. If you don't do it in the moment, you'll be there till midnight, missing out on your family trying to take care of that. There's the EMR. And then there's also the artificiality, I think, of the medical setting. Right? Doctors' offices, hospitals, they're cold, physically, psychologically, people are uncomfortable. When I don't have a lot of time for house calls, and often I only end up doing that when my patient is very sick. Every time I do it, I think, gosh, why didn't I do this sooner? I really get to know my patient when I visit them at home. And interesting, now that we're doing some video visits through, during the pandemic, that's given us a bit of a halfway point of that. So the setting can often be difficult. And don't forget, the patient's often not in their best moment when they're seeing the doctor. They may be in pain or worried or terrified. All these things that make it not the most comfortable setting. And so it would be so nice if we were able to do other settings to help that out.
Right. And personally, I've been to the hospital multiple times. I worked as a medical scribe at the emergency department. I've seen physicians struggling with like EMR system, like the time constraint. So I see a lot of like mention of time. So how does that 15-minute visit came into being? Why is it 15 minutes?
And in a lot of places, not even that long. So it all goes back to, well, how do we finance the healthcare system? And, as much as we all want to sort of hate the for-profit mode, of which I am not a fan of, I mean, I recognize that hospitals, and they have to get some revenue to keep the lights on and pay the people. So I want them to appropriately, to be funded. But how is our funding ever set up to begin with? Who was at the table when we came up with how we fund medical care? It certainly wasn't pediatricians and primary care doctors. It was mainly specialists. And so we came up with this fee for service system that sort of defines services. And those are things that are then reimbursed. Sitting and chatting with your patient, that's not considered a valuable thing in terms of what we reimburse. And I like to joke, diabetes, it makes up a big part of my care. So many patients have diabetes, and diabetes is really about education and talking to patient about, what to eat and how to exercise, how to take your medications. It's a lot of talking, not a lot of procedures. And so what I often spend half my visit describing to my patients how to switch from white rice to brown rice, because it's much better for their sugar. And I even give them my recipe. And, so if I sit there and talk about that, Medicare is not going to reimburse very much to my hospital for me talking about how to cook brown rice. But if while I'm talking about how to cook brown rice, I simultaneously pass a tube or a catheter into one of my patient's orifices, and you can pick any orifice you want, the reimbursement goes up like 15-fold. And if I were to run a CAT scan machine over there at the same time, you're talking big bucks. So our system is so set up to pay much more for that than for the talking to the patient about how to, deal with your illness. And so in order to keep the lights on, you have to see as many patients as possible. And so we cram the time shorter and shorter to fit in enough patients to get enough revenue to, pay the rent. But then there's also many places there's a strong profit motive that the more procedures you do, knee replacements bring in much more money than talking about how to, control depression or congestive heart failure, or drug addiction. So, and you see why so many hospitals do knee replacements and not a lot of the other stuff.
That makes so much sense. I also have a question on like insurance and how that relates to the doctor-patient relationships. How does the third parties like insurance affect the relationship between provider and patients?
It makes me think like there are three people in the room. There's the doctor, the patient, and the insurance company, or four if you count the EMR as another player in there. But it plays a big role. And I have one patient in particular who's really struggling with her diabetes, and and her asthma. The medications that I think will do the best help for her become prohibitively expensive. Even when they're covered, the coverage is so flimsy that in practice, it's just out of reach. She's a retiree, lives on a fixed income, can't afford them. And so we struggle, and I can't find a good combination of medications that work that she can afford. And part of me wants to tell her, just ditch your insurance and come in as a self-pay patient, to our charity hospital. But that's not the way. I don't want to tell her that, because I want her to have insurance, but it's such poor insurance. And so many medications require prior authorization and hoops. The patient emailed me yesterday, call my insurance company about my MRI. Well, that could take me a half an hour, and it's not like anyone gives me half an hour to work these things out. And so I have to squeeze that in somehow and, lose time from other things. So it's constantly playing a role in what we choose to do. And I feel, and not that we are perfect or omniscient, but I feel as though I want to, offer when patients say to me, oh, if I take that medicine or I do that test, you'll make more money, right? And I'm so happy to say, no, I'm a salaried employee. My salary is the same, whether or not you do the CAT scan. And so I feel like I can make a recommendation that's, as good as I can. It's not perfect by any stretch, but as good as I can. But then I'll have to get on the phone with an insurance company person who really knows nothing about this, and try to make my case and really grovel with them to beg, could you please cover this medicine? And it feels like such a warped way to use our resources. And I understand we need to have, control. Some of the medications are very expensive, and that's a whole other discussion why they are so expensive, but we need to have some price controls. But right now, the insurance company feels like we're going through hoops all the time. And that's just so exhausting for the patients and for the clinicians.
Right, right. We need you to practice medicine, not battle with insurance, right?
Yeah.
That's a real struggle right there. So I had a chance to watch one of your TED Talks, Deconstructing Perfection. I love how you describe all those like medical cases. But I had an interest for like your topic of like how the culture of medicine has a zero tolerance for medical errors. And I believe that this may be contributing to the issue of creating like great doctor-patient relationships. So how does the fear of medical errors affect doctor-patient relationships?
I mean, we're all rightly concerned about improving patient safety and decreasing errors. There was a study a couple of years ago saying that medical errors were the third leading cause of death. It's probably not that high, but it's not small. And so it's clearly an important issue. And so we're putting a lot of resources toward there. Now, one thing that makes me worry is when we have this idea, but we're going to have zero medical errors, we're going to have none at all. Well, that's not possible, right? This is a human endeavor. We're people, and thankfully. And I think when we try to say, well, it's going to be zero medical error, then people are just going to hide it when it happens. I mean, who wants to be, the person who's singled out because they're embarrassed, they're ashamed, they don't want to. I mean, most doctors who are in there, nurses, they don't want to make an error. So if they do, they're terribly embarrassed and very ashamed, humiliated. And so the insistence on the zero tolerance part, I think, will just have us not game the system. That implies a little too much, it's a little too flip, but to not talk about errors that happen or near misses, which is of course the landmine waiting to happen. And so I think that it's more realistic to look at is how can we sort of shift the level of safety, a little more in the patient's favor? How can we make things, safer? How can we have an environment that encourages doctors and patients to come forward when there's, a less than optimal outcome, with the goal of not yelling at them or firing them or making them do remedial education, but say, hey, you are so brave for coming forward because we would never know about this problem if you didn't. Thank you. Now we're going to give you the resources to help solve it. And that's where we want to be going with medical error. In the US, our malpractice system is really predominant. So we are rightly afraid of being sued. So we end up practicing defensive medicine. We overorder tests in a big way compared to other countries that don't have this. If you look at the Danish system, in fact, all the Nordic countries have really moved away from this sort of punitive thing about let's find the person to punish, but let's compensate people who have been harmed, even if we find no personal culpability, and let's solve the problem. So they have a patient compensation system. It's a little bit like workers' comp here, where you can file a case very easily. The doctor can help you. And if you've been harmed or your medical care wasn't as good as it should be, you get a modest payout to sort of compensate you. And the data are collected not with the goal of trying to hound and throw out all the terrible bad apples. And if there truly are bad apples, yes, we should get rid of them. But for most doctors and nurses, they're just trying to do their best. But there's usually a reason why an error happened. No one goes to work saying, hey, I want to harm my patient. But a nurse may have too many patients to take care of, and so inadvertently makes an error. And if we can figure that out from the patient compensation, reports that are filed, then we say, hey, here's what we have to do. We need more nurses, or the lighting isn't good enough, or we have a distracting system, or there's one great example of in the operating room, there's hoses for nitrogen and for oxygen. And for years, every year there'd be a couple deaths when those hoses got mixed up. So they finally color coded them so it would be harder to mix up, but there are still a few. Well, they finally made the valves and hoses different sizes, so you can't possibly mix it up. Like, why make the anesthesiologist remember red, blue? Just make them so that you can't mix them up. It's like your food processor. You can't turn it on unless it's locked. And there's so many places you can improve patient safety by making errors less likely to happen. But you have to know where the errors are occurring. So you have to make an environment that allows nurses and doctors to feel comfortable to come forward without being afraid of being screamed at or fired or shamed, to help make it safer for all patients.
That's great. It seems that there's so many factors going into medical like interaction that it's not just the provider, it's not just like the healthcare team that affects all of this. It seems like the whole like system of like hospitals, some of the policies that the government places, all of that is factoring in. So I'm curious, do you have an example of like a good patient, good doctor-patient relationship that you remember?
Yeah. I have a patient. Actually, he's my longest term patient. And I got him when I was an intern. He was discharged from the hospital after a heart attack. Any new MD in the clinic, and I just happened to grab his chart. We're still together. I won't even tell you how many years that is, but it's a lot. And a couple of years ago, his cardiologist recommended that he get an implantable defibrillator to essentially shock him if his heart were to go into a fatal arrhythmia. But he hasn't had the problem yet. So you're doing a procedure when it's a preventive procedure, but of course it has a risk. So it's, it's a big decision. And he didn't want to make the decision. He said, Dr. Ofri, you tell me what to do. And no matter how much I tried to engage him, and he wouldn't. So I really had this responsibility, and I tried to weigh, he had grandchildren he was helping to raise, and he'd been doing well so far. And I thought probably the benefits outweigh the risks, so I recommended it. Anyway, he had every complication you can possibly imagine. It was the biggest nightmare. The thing kept going off, and each time it goes off, it's like being struck by lightning. And he was miserable. Every medication complication. He finally said, turn it off, take it out. And he came out of the hospital, 2 weeks later, looking like he'd aged 20 years. And I felt terrible because I had recommended this. He said, tell me what to do. And I told him. And I remember saying to him, I completely understand if you want to switch doctors, right? I gave you advice. It was disastrous. And and he didn't. And he said, I understand the difference, between you gave me your best recommendation. It didn't work out. It doesn't mean your recommendation was bad or that you weren't being careful. And it was this absolution and forgiveness that was so powerful. And I realized that I wanted to actually get to know him better. And at the time, I had run into a documentary filmmaker making a film called Why Doctors Write. And so I asked this patient if he wanted to be part of it, and he did. So we ended up, participating in interviews for the documentary, being part of the film together to really get to know each other. But, that experience of coming close to, having a terrible outcome, and that we had these years of relationship, I think if we didn't have that, he could have sued me. I mean, he would have had grounds for that, certainly. And maybe there would have been a settlement, and, who knows, but the relationship allowed us both to move on, and we're still together even to this day.
That's great. That's such a heartwarming story, and I'm glad it ended all well for you and the patient as well. So that sounds like a great relationship to be having as a doctor and a patient. Is there an ideal way for this to be formed?
The ideal way is obviously before disaster happens. So ideally in primary care, you want to see your doctor when you're perfectly healthy and find someone you like and trust and get to know them over time, so that when something happens, a difficult diagnosis, an emergency, there's already someone and you have a sense of them and they have a sense of you. And so often we don't have that, and something happens, you have a heart attack and you end up in a hospital and there's doctors you've never met. It's often not ideal, but the ideal thing is, before it happens, with your general pediatrician, primary care doctor, family doctor, getting to know them, your nurse practitioner over the years, and you get a sense of each other. We all have different styles of practicing medicine. Patients have different styles in terms of, how risk averse they are, how willing they are to try new things. And it's helpful to know that. So that's ideal. We often don't have that. But even when we're, meeting someone for the first time, unless someone is, hemorrhaging or in cardiac arrest at that moment, there's always 5 minutes one could find for a little bit of, tell me a bit about yourself. Tell me what's important to you. As we go through this hospital stay, we'll be making decisions together. Is there anything that you'd like me to know? And, there are some patients for whom, for example, some elderly patients would say to me, I don't want to know the details. Tell my adult child and let them, I'd rather not know. That's good for me to know. And if I haven't a chance to ask that, I'll never know that. Or someone will say, my religion is very important to me. And for that reason, I never want to do X, a transfusion or things there. People have different things, and helpful to know lots and lots of things. And just a sense of, what's important to you. If something happens, who should I talk to? And let's bring that person in the conversation now. So finding the few minutes, it's rare that we never have time. There's a few cases, obviously, we got to act first and talk later, but nearly all of the time, we can take the time if it's on our mind to do so. And I think if the onus is on the doctors and nurses to take the extra minute and see about that. Now, if you're the patient and they don't, you could stop and say, hey, there's a couple things I want to tell you about myself that you need to know if you're taking care of me, and I need 5 minutes of your time. If your doctor or nurse can't give that time, then you need to ask for someone else. I really think that nearly everyone should be able to find that few moments to give you that undivided attention.
That's great. It seems like the human connection is always should be like the first step that you establish so that they feel comfortable and like warm enough to warm up to the providers and give the information that they need.
Yeah, and
So
also add to that, often there's many things that people aren't comfortable talking about. Domestic violence, sexual abuse, depression, eating disorders. These are things that people don't bring up on the first visit. You have to trust someone. It's very intimate to talk about those things, suicidal ideation. And these are serious issues that cause our patients much harm and much suffering. And if we don't create an environment to allow our patients to share that, we will miss the diagnosis. We will not be able to take adequate care of our patients. And so we are really, I once had a young woman who came in about a scalp condition. And she said to me, we were looking at her scalp condition, that she also had these, aches and pains sort of random places in her body. And I examined her, there was nothing there at all. So I gave her cream for scalp condition and said goodbye. And she's walking and she's outside in the hallway, hands still on the doorknob. And then she says, "Hey doc, do you think it matters at all that the parts where I have pain is where my ex-boyfriend shot me with a dart gun?" And I realized that I had completely not considered domestic violence, intimate partner violence. And had she not had the courage to hang onto that doorknob and tell me, but I should have been alert to that. And so I pulled her back in the room. And of course, I missed the boat, potentially missed the boat on a really critical diagnosis. And I was able to get her help. And you can't do these things without a good, solid relationship.
that's great. I remember you mentioned like how it's important to establish like long-term relationship with your primary care physicians or pediatricians. But I know for a fact that some like younger, like healthy adults don't like to have that relationship because they think they're healthy. They like it's a waste of time and money to go visit like primary care doctors. So how do you encourage like patients to continue seeking their primary care physicians, doing the yearly checkups?
I think it's really important. It's funny, we talk about it as the annual physical. It's really the annual history, it's the annual conversation, because the goal is not about treating disease, it's making you healthy, right? As healthy as possible. And so we want to see our young patients to talk to them about eating a healthy diet and exercising and wearing bicycle helmets and seatbelts and sunscreen, using birth control, STI surveillance, all of these things, vaccinations that, healthy people forget about, but there's so much there in terms of, I was talking to a young healthy person and in asking about their diet, I discovered they drink a 2-liter bottle of soda a day. And, that's a huge intervention. Like, you know how much sugar is in a 2-liter bottle? It's like a cup of sugar it's like just eating the bag of sugar. And if we didn't have that conversation now, 20 years later, this person might be in there with diabetes, or maybe all their teeth have fallen out and they end up having to get dentures as a young person. Or they're struggling with obesity later in life. So there's so much we can do. So I do recommend it going as to see your primary care nurse or doctor, how can I help myself get in the best health possible? Because, without that, it's pretty hard to pursue anything else in life if your health is suffering.
Thank you so much for today, Dr. Ofri.
You're very welcome. If I could take one moment, I just want to share the Bellevue Literary Review. This is our literary magazine, and we publish fiction, poetry, and nonfiction about health and healing. Because I think that so often we talk about illness, we think about, the top 10 tips for osteoporosis, but that's only part of it. The other part is grappling with vulnerability and the human condition. Often the arts, poetry and fiction, is a much better medium for that. So I introduced Bellevue Literary Review, and please visit us on the web and take a read. It's full of great things to read. It's not commercial, we're an independent nonprofit. So Bellevue Literary Review.
Thank you so much, Dr. Ofri.
You're very welcome.